Welcome, everyone, to Trans Advocacy Network's monthly webinar. This month, we're talking about trans healthcare. We're going to give you a part 1, and later on down the line, we'll give you part 2. Today, we're talking about laws and landscapes, and we are very fortunate to have with us Milo Primeaux from the group Other, who will be presenting on the topic. I want to give you a little heads up about what the purpose and agenda is today. So if we could go to the next slide, perfect. So the purpose, as you can see right there on your screen, is to educate advocates about the current legal landscape of health insurance and healthcare access for transgender people. We're going to start with what the current landscape is, talking about the Affordable Care Act, also known as Obamacare, what it does and doesn't do, what's happening at the federal versus state level, how insurance companies justify discrimination, differences between public and private insurance, and then we're going to talk about where we're going, how you can get involved, how other folks have made changes in their states, and then we'll have time for Q&A. I hope that sounds good to everyone. So to get you all ready for this, we are going to just give you a quick rundown right now of how to use this webinar software so that during the course of things, everything goes smoothly. So first of all, I want to point out that you should see a control panel on your screen. It should look basically like the one on this slide here. If you don't see that, it may be because the little red arrow, which is the first box that I've highlighted here, is pressed to make it hide the panel. So if you click on that, it'll pop out onto your screen. You'll be able to see the control panel. Next thing I want to highlight is if you're having any trouble hearing through your mic and speakers, you can also click that radio button for telephone, and it'll give you a call-in number that you can use. If you are using mic and speakers and you're planning on asking questions during the webinar, highly recommend using headphones so that we don't get any feedback back into the audio, which will kind of gum things up and give us some echoes. If you have questions at any point during the webinar, you can raise your hand to speak or type to ask a question. We will have time at the end for folks to ask questions out loud. We find it works best if people type their questions during the webinar and do the verbal questions at the end, just so everything runs kind of smoothly. So to make sure that everybody has a handle on all of that stuff, I'm going to ask everybody right now if you can find that raise hand button and raise your hand so that we can make sure everybody's got a hooked into how things are working. I see a couple people's hands are coming up, a few more. All right. Okay, looks like most people are figuring out how to do that. And then now I'm going to use my supreme power to put everyone's hands down. And yeah, so it looks like everything is going well with that. So again, if you have any questions during the webinar, go ahead and type them in the chat box and I'll answer those for you. And otherwise, we are ready to go. A little bit about who's on the webinar today. Milo Primeaux, as I said, is the founding director of the Organization for Transgender Health Empowerment Resources, shortened to Other. He's an expert on the topic. He is an attorney, and he's based currently out of Washington, D.C., has been in New York for quite a number of years and a number of other places as well. And my name is Anand Kalra. I forgot to say that at the beginning. My apologies. I'm the program administrator for Trans Advocacy Network. So quick questions for you all so that we know who we're talking to. I'm going to run a couple of polls here. Here's the first poll. What level of experience do you have with trans health activism? Go ahead and click your answer there. If you are calling in on the phone, I'll read the answers to you, or what the options are, which are totally overwhelmed and confused, sure on some parts, weaker on others, and confident in all areas. Okay, seeing 64% of folks have participated, and a few more. Okay, all right, with 93% reporting, we are seeing that 15% of people are total beginners, about 70% feel like they're intermediate, and 15% are confident in all areas. Excellent, thank you for participating there. And next question is, does your state have a non-discrimination bulletin for health insurance? Options are yes, no, not sure, and what does that even mean? Give folks a few moments to put their answers in. Okay, with 92% reporting, we have 46% are saying, yes, my state does, 23% are saying no, and 31% are not sure. And that is just fine. We're going to explain to you what that means and let you know if you do or not. All right, so with that, I will hand it over to Milo, who will present the rest of the webinar.
All right, thank you so much, Anand. It's a pleasure to be here, and hi, everybody. All right, so we're going to get started. To begin, we're going to talk about the current legal landscape. As Anand went over, these are some of the bullet points that we're going to discuss in the course of this section. So let's get going. Some consequences of legal barriers to healthcare. Some of these, as advocates, you may already be pretty familiar with, particularly from the Injustice at Every Turn report that was published by the National Gay and Lesbian Task Force and the National Center for Trans Equality in 2011. Really great resource. Highly recommend taking a look at it if you haven't already. But some of the consequences of legal barriers that we have. Trans folks have difficulty accessing transition-related care or gender-affirming health care, which seems fairly obvious, but I think sometimes more problematic, actually, is difficulty accessing healthcare generally. So we're talking about routine preventive care, cancer screenings, et cetera, which will lead to unchecked health issues and increased health risks and costs overall. We also have increased instances of depression, anxiety, and substance abuse, both from not being able to get gender-affirming health care and the secondary issues that are exacerbated by that, but also having less access to competent providers who can treat these conditions. We also have drastically increased suicide attempts. According to the study, those who responded to the study, trans people who did not have access to transition-related care were up to 30 times more likely to attempt suicide than those who did get to access care. We also see higher instances of utilizing illegal and dangerous channels to access hormones and surgery. And we also see that this increases barriers to accessing appropriate gender-matching government IDs. So a number of states and jurisdictions require that you undergo hormones or have what's called sex reassignment surgery, usually is referred to in the law, and provide extensive proof of these things in order to get your gender marker changed on your IDs. So if you're not able to get that changed, you might end up being susceptible to unemployment or underemployment, employment discrimination generally, insecure housing or homelessness, run-ins with the criminal justice system and the police, various forms of discrimination, harassment, etc. I realize at this point that this is not a very uplifting picture of the way things are, but I think it's really important to be realistic about the effect that it has on our community, and then we can look forward to some victories that we have to see how it's getting better. So also pulling from that same resource, the Injustice at Every Turn, we could kind of look at least up to 2011 what some of the disparities are as far as health insurance goes by race. So here we could see that white and Asian people are actually, those who responded to the survey were the least likely to be uninsured, and also the most likely to have insurance that was through an employer that they were able to purchase on their own. We see that Black, Hispanic, American Indian, and multiracial were more likely to have insurance through public insurance avenues such as Medicaid or Medicare, or to be uninsured altogether. The reason why this is important is because comprehensive and adequate insurance really does open the doors to a variety of healthcare options, even if it's not transition related and gender affirming related. If it's for a variety of other medical and mental health needs, having access to that insurance is critically important to have those needs met. We also see disparities in access to care generally, and we're talking about those who responded to the survey, which there were over 6,000, of them, who was refused care. So of the total sample, almost 20% of the sample size from the study were turned away from care altogether by a provider. That's where a provider said, you know, I don't know how to treat a transgender person, or I refuse to treat you, you have to go away. Of that 20%, the rest is the breakdown here. And we actually see a very high rate among American Indians who responded to the survey. And finally, this is the last chart we're going to look at for right now. The first two columns here on the far left show that the general population shows a 0.6% HIV infection rate. And that's compared to the survey total. So of all those people who responded to the survey, 2.64 were HIV positive. So this is over 4 times more likely. Trans people who answered the survey were over 4 times more likely than the general population to be infected with HIV. And the rest of the columns show the breakdown thereafter, and we can see that the African American and Latina community are particularly affected by that. So that's all important because the intersectionality of health disparities is something that we have to take into consideration when we're talking about access to health and health insurance. Race and economic class are critically important. So now that we've kind of had a look of what some of the legal barriers can do, the harm that they can cause, let's talk about what the Affordable Care Act actually does and what it does not do to try to correct some of those issues. So the Affordable Care Act is a federal law that was signed in 2010. Before that, an estimated 50 million Americans were uninsured. But because of the ACA, there will be an estimated 34 million newly eligible people by 2021, and that's newly eligible for insurance of some kind. This is kind of leaving out the non-citizen population that are not otherwise eligible for some sort of insurance or could not afford some sort of insurance, so there's still a gap. And of that 16 million, it's not really possible to say how many of those would be trans-identified, but it could include undocumented citizens or those who have been denied asylum or refugee status and that sort of thing. So why does the ACA work? Well, it includes a statutory scheme to insure all citizens. And it goes at a whole bunch of different angles. So one way it does it is by offering to expand state Medicaid programs, which we're going to talk about a little bit more in a second. It also implemented a whole host of insurance market reforms that are supposed to give health insurance consumers more rights and to restrict unfair practices by the health insurers themselves. It also created and opened and runs these health insurance exchanges, which are these online marketplaces where people can go and find affordable health insurance, either through purchasing a private plan with subsidies from the government or accessing Medicaid or Child Health Plus for children. So specifically with regard to how this can impact transgender people, some of the best benefits are the fact that the ACA enhanced HIPAA rights, which are federal civil rights to privacy of health information, and really reinforced those and bolstered those. Also, insurers are prohibited from denying coverage to individuals based on pre-existing conditions. So just because somebody has, for example, HIV or gender dysphoria, that will not keep them from being able to get insurance. It used to be the case up until the Affordable Care Act that if you had a pre-existing condition, insurance companies could deny coverage for that condition for up to 12 months or more, depending on the state that you were in. Preventive care must be provided free of charge. And we're going to roll back to this in a little bit, but this may not be entirely as helpful for the transgender community as we would like it to be. Here we touched on this a minute ago, Medicaid expansion. So states can choose to offer Medicaid to folks with household incomes of up to 138% of the federal poverty level. So in 2014, that's anything less than $15,856 a year for an individual. and that goes up as you add individuals to your household. This is significant because before the ACA, Medicaid was capped off at 100% of the federal poverty level and was usually only available to parents of minor children and who had children in the household and children themselves, and people who fell into a certain few other categories like pregnant women and people with disabilities. Now, in Medicaid expansion states, the ones who took on Medicaid expansion, you're eligible for Medicaid based on your income alone. And they don't do resource tests or asset tests and take into consideration a lot of other variables. It's just focusing on your income, which is really helpful for people, especially those in our community who are largely low income. All right, so it also includes, the ACA also includes a non-discrimination provision, the infamous Section 1557, which the U.S. Department of Health and Human Services, which is the federal agency that's implementing the ACA and making it happen, making it real for the rest of us, has interpreted this provision, the part specifically that says based on sex, so non-discrimination based on sex, to include actual or perceived sexual orientation or gender identity of an individual. So what this boils down to, though, is that an insurance company cannot deny coverage to somebody just because they're a transgender. So if a transgender person approaches an insurance company and says, I'm trans, but I need insurance, they can't say no based on that reason, which is great. Something we will see, though, this is what the ACA does not do yet. It does not guarantee that there will be comprehensive health coverage for that transgender person as far as transition-related gender-affirming health care goes. So here again, the trans person goes to the insurance company, gets insurance, but that insurance plan that they get does not have to include transition-related care. Another point I'd like to make is that although the ACA bans discrimination based on sex, it does not remove gender from the equation of insurance altogether. I think in the work that I've seen that this might be part of the next frontier of what we need to push for. Previously, gender was taken into consideration with regard to whether somebody could get insurance because of increased health risks, if they were a certain gender and a certain age, and also increased premium price. And the premium is the amount that you pay per month for your insurance. So for example, if you were a 23-year-old female going for insurance, it's quite possible your rate, your premium rate, would be much lower than a 56 or 57-year-old female going for insurance who maybe has already gone through menopause or coming close to menopause and will thus have increased risk for osteoporosis, various cancers, and things like that. It may have higher health risk. However, under the ACA, none of that can be taken into consideration. Age, gender, none of that can be taken into consideration. The premiums are the same across the board. So why it is we still have to base the policies on gender is really questionable. And we'll talk in a minute why that's particularly problematic. So just to take a really big picture look at what we're talking about here, the Affordable Care Act, like I said, is a federal law. Federal laws establish a floor, not a ceiling. So states can create laws that build upon a federal floor, but they cannot create laws that conflict with federal laws. So with regard to what we're talking about, without federal laws and regulations specifically protecting transgender individuals that focus on providing comprehensive coverage for trans people within the plan packages themselves, insurers are free to deny coverage for transgender-related services unless states pass their own laws, regulations, and policies banning these exclusions. So until federal law changes to be more inclusive, state laws can step up and do it themselves. Without that stepping up, though, if you're in a state that has not stepped up yet, you're still susceptible to some of the discrimination that can be built into the insurance. So what does this look like? What kind of discrimination are we talking about here? So the most common one, and this is in the vast majority of health plans, unless you're in a state that has banned them, are what we call categorical exclusions. So these are explicitly naming transgender-related services under a policy's list of excluded services or in a state Medicaid regulation. So if you were to look at your insurance policy and you flip through it, you'd see all the things that are covered. You can go to your primary care doctor, you can maybe get dental work done, go see a gynecologist. But if you keep flipping through to the back, you'll see a list of excluded services, and including often things like infertility treatments or cosmetic surgery, usually listed there as well as this categorical exclusion that might be called sex or gender change, sex reassignment surgery, or my personal favorite, sex transformation. It's like you're a butterfly, but no, you have to stay in the cocoon. No sex transformation for you. So why this is particularly problematic is because it doesn't tend to just affect gender-affirming services. It also tends to affect other things that it should be available to all people. For example, going back to why gender is even in the equation here, preventive services like seeing your primary care doctor, your regular annual screenings like mammograms, if you have breast tissue, prostate exams, pap smears, things like that, all of that should be free under the Affordable Care Act. However, we're seeing some insurance companies are using their categorical exclusion in the plan to say that, okay, if you're transgender, then you can't get a prostate exam because you are identifying as female, and females do not need prostate exams because they don't have prostates, right? And vice versa for female to male transgender men. We're seeing them take a categorical exclusion that's kind of focused on gender-affirming services like hormones and surgery and maybe behavioral health services, and kind of expanding it to sex-specific services that transgender person may need for their body. We're also seeing them use things like transgender-related to really reach out really far to try to deny coverage for a whole host of other things that have nothing to do with transition. One example from a transgender law center publication is where a female-to-male trans man has a heart attack. He's treated at a hospital and he recovers. His insurance plan denies coverage for the treatment, claiming that the heart attack was related to this patient's hormone replacement therapy, his testosterone, and was thus transition-related, which is categorically excluded from the insurance plan. So as you can see, this is a pretty far stretch from what that exclusion is supposed to be focusing on, but we see it happen all the time. So regardless of whether or not there's actually an explicit categorical exclusion for transition-related care, insurers might also use some of the following reasons. They may say, instead of saying, well, this is never covered, they might say, well, this is not medically necessary for this patient. That sort of basis is based on the assumption that hormonal and surgical intervention are not an appropriate treatment for a mental health diagnosis. It's usually what they're getting at. However, there's usually, there are a number of professional association statements of support around medical necessity and insurance coverage that have been published and are actually available on Lambda Legal's website. They've compiled them all into one easy to download sheet of all the different professional associations who have come out to support us, like the American Medical Association, American Psychological and Psychiatric Associations, etc. There's also a somewhat recent, now I guess it's not so recent anymore, how time flies, tax court decision that actually approved a deduction on a trans woman's taxes based on the fact that she had medically necessary transition-related care. So the tax court found it to be medically necessary and therefore tax deductible. So there is some movement toward finding it medically necessary, but that's another way. Other somewhat less common reasons now, they've kind of gone out of vogue, is calling it experimental, which is based on the claim that the treatment is not generally recognized as effective by the medical profession, where the insurance company says that there's insufficient research and there's no FDA approval for hormones and surgery for this instance. So my big push is always to say we need more research to be published, right? So if you see any opportunities to partake in research, I highly recommend that you do so and that you encourage your communities to do so, because the more research we can get, the more we can use in our arguments to fight this sort of discrimination. But also there's more and more research that has come out. So typically the insurance plan is looking at studies that were conducted, if any, from the 70s or the 80s with very small sample sizes and very old techniques and also very old understandings of what transgender means. But the field has come a long way and has become much more refined in thinking about these things, and there's quite a bit of research actually available. So usually to fight this sort of discrimination just requires gathering some of this research together and sending it in with an appeal to the insurance company. Lastly, they might say it's cosmetic, which is based on the assumption that the treatment is purely elective and thus not medically necessary. This one is becoming less and less common. There's some decent case law in a variety of states where a case has gone to court and a judge has decided that using that particular reason is particularly incorrect and baseless. So that's a less common form of discrimination these days. Okay, so I know that this is kind of small font, and I'm not going to read this word for word, but I do want to kind of highlight what the differences are between public health insurance and private health insurance and why these differences are important as far as advocacy goes. So public health insurance, we're talking about insurance that's paid for by the federal government and or by the state that you live in. So Medicare is a federal program that's available for people who are 65 and older or disabled, or also those who have end-stage renal disease. That's not included. As of this year, as of May 30th, 2014, there was a huge victory, and Medicare actually no longer has a categorical exclusion in its coverage for transition-related surgeries. So that's a really big change. That was in place since the late 1970s, early 1980s, and was mostly a baseless exclusion that didn't have any evidence kind of backing it up. So it was pretty easy to overturn when somebody challenged it, but the challenge was really necessary, and the victory is really good because a lot of insurance companies kind of look to Medicare as the base of their benefits and their coverage and their rates. So the fact that Medicare has overturned their categorical exclusion is a good sign that there might be a domino effect in the coming years. So to distinguish, Medicaid is a state program that's paid for mostly by the states for low-income folks. Particularly those states that have accepted the expanded Medicaid, that extra money for the expansion to go from 100% to 138% actually comes from the federal government. So it's kind of a dual program, funded program. So most states' Medicaid programs either explicitly exclude coverage for transition-related healthcare in their regulation, in the state law itself, or they're silent on the issue altogether, which basically means that if there's no exclusion, then Medicaid can choose on a case-by-case basis whether it wants to deny it for one discriminatory reason or another that we already described. In either case, I highly recommend and urge you all that if you have Medicaid or Medicare, you should always appeal claim denials. If your doctor or your surgeon sends in a claim for gender-affirming care, and that claim is denied, particularly for Medicare since that's been overturned, you should always appeal it and fight it and send in more information and research and try to get it overturned. Also, Medicaid comes with, because it's a public benefit, you have a fair hearing right, which means you get to go before an administrative law judge. Usually it's just you, the judge, an advocate if you want to bring one, and someone representing Medicaid or the city. And you get to present evidence to the administrative law judge as to why this care is medically necessary for you. And even if you don't win, those those decisions that the ALJ make become public record. And that public record gives you something to go to court with if you want to do that too. But you would have to exhaust all of your administrative remedies, which is going through the whole appeal process and doing a fair hearing. So you have the right, you should always exercise the right. That's what I say. All right, moving on to private health insurance. So private health insurance is what you either purchase on your own through a health insurance exchange or on the broader marketplace, or you get it through your employer. There's an important difference with employer-based insurance. Your insurance through your employer is either fully insured or self-insured. I'm not going to go into a lot of depth as to the differences between the two because it gets complicated, but the basic difference is this. Fully insured plans, if you have one, your insurer pays for your claims when you get sick. So if you go to the doctor and the doctor sends in the bill to the insurance company, the money to pay for that bill comes out of the insurance company's pocket. So those plans are regulated by state agencies in your state. If you have a self-insured plan, then when you go to the doctor and the doctor sends the bill to the insurance, your employer actually pays for that bill. So it comes out of your employer's pocket. Self-insured plans are largely regulated by ERISA laws, which are very complicated federal laws that even ERISA experts get a headache thinking about. So we're not going to talk about it much, but they're regulated by the U.S. Department of Labor. The reason why it's important to know which one you have is because there are different appeal processes and different rights. And it's really important to know which one you have and who to go to fight a claim denial. So on top of federal protection, states can pass broad gender identity and gender expression non-discrimination laws that would impact insurance companies. We'll see in a second a list of states that have done this. In addition to this, usually, or if the state hasn't done this, using some other legal basis, state agencies that regulate insurance can also issue what's called administrative bulletins or policy bulletins that interpret non-discrimination laws and regulations to apply specifically to insurance companies in that state. So for example, if you live in California, there's a law on the books that prohibit discrimination based on gender identity and gender expression. The agency that oversees fully insured insurance plans in that state looked at that law and said, well, okay, then that means that no private insurance plans that sell fully insured plans in the state can have categorical exclusions for transition-related care because that would be violating the state's non-discrimination law. Other states that don't have this might use unfair discrimination practices in their insurance law or some other law to base this policy bulletin on. We'll look at that in just a second. Either way, I just want to kind of drive this home again. If you have a private insurance plan, even if it's fully or self-insured, it doesn't matter. You should always, always, always appeal your claim denial. It doesn't matter what reason they give. You should always appeal it. You want to go through the process of appealing. It's really important. Also, if you're at the last step of appealing and you still haven't gotten very far, I'm always an advocate of sending a copy of the whole appeal process to your state attorney general's office, just to let them know what's going on. You know, trans health access is a really hot button, sexy issue right now. And a number of attorney general's offices who are in charge of enforcing the laws of the state and defending the laws of the state will see these discriminatory practices as an opportunity to take on insurance companies or take on unfair practices. So it's good to let them know, and you never know, you might be surprised at their reaction. Okay, so now we're just going to look very briefly at the states that have been successful in making their insurance inclusive of transition-related and gender-affirming healthcare under their state law. So we see California, Colorado, Connecticut, Illinois, Massachusetts, Oregon, Vermont, Washington, and Washington, D.C. have all issued policy bulletins. This is what Anand was asking about in that second poll, that basically ban categorical exclusions focusing on transgender people based on laws that they have on the books that prohibit discrimination based on sex or sexual orientation or gender identity. Each one of these states has done it slightly differently, and it's very interesting to see how they've done it. You can Google this with any of these states. You can put in the name of the state, something to the effect of policy bulletin, insurance, transgender exclusion. And I guarantee that something will come up, either a news article or a link to the actual bulletin that was issued. Maryland did sort of a half-hearted attempt. It issued a bulletin that clarified that categorical exclusions for transition-related care are okay. They just can't extend to bona fide non-transition-related treatments. So again, the concern we were talking about before, where you just need to get preventive care, or you have a heart attack, or you have something, you dislocate your kneecap. None of those things are necessarily transition related, and therefore the insurance companies in Maryland can't extend their exclusion to try to not pay for those other claims. Now, Medicaid, again, for the large part, excludes transition-related care, but these states and Washington, D.C. have been successful in getting their Medicaid to be transgender inclusive, which is phenomenal. And we see that, this has all been happening in the last just couple of years. So the momentum is definitely building around this particular method of overcoming these challenges. So that's kind of a taste of where we're going. Let's dive into it a little bit more. So as I said before, Medicare's longstanding categorical exclusion for transition-related care was overturned in May, so that was huge. There's a great deal of increased pressure on HHS, which again is the federal agency that is implementing the Affordable Care Act, to issue more inclusive guidance on the non-discrimination provision, Section 1557, to clarify that categorical exclusions of transition-related care should be prohibited under the ACA. So basically we want them to say, it's not enough to offer a trans person insurance. It has to be insurance that actually meets their needs. There's also been increased pressure on Congress to pass transgender inclusive ENDA, which would add some protections for employees and hopefully get more transgender inclusive employee benefits. Also, there's been increased support by national professional associations around the medical necessity issue, which we talked about before. So just to talk about state reform efforts, we looked at all the states that have been successful so far, but I just wanted to touch on an example of a state that is currently in the process of trying to achieve some of these victories, and I think is illustrative of what can be done in other states that have yet to get started or just getting started, or that are struggling, because this kind of exemplifies the multi-strategy approach that somebody can take. So in New York, which Anand said I did spend quite a bit of time, so I'm a little knowledgeable about New York. There's currently a legal challenge brought by the Sylvia Rivera Law Project against New York State Medicaid's categorical exclusion of transition-related care. There's also a lot of pressure being put on the New York City, actually, policy to change their gender marker change policy for birth certificates of people born in New York City. You may not know this, but if you're born in New York City, you get a different birth certificate than if you're born anywhere else in the state, which is fun. But a lot of pressure was put on the State Department of Health to change their policy so that you didn't have to show such extensive proof of sexual reassignment surgery, but rather you could just say that you're under appropriate medical treatment for your gender transition, which is a much, much softer requirement, much easier to comply with. So now if you have a birth certificate in upstate New York, you can get your birth certificate changed rather easily by comparison with New York City. But there's currently a lawsuit in progress by the Trans Legal Defense and Education Fund to try to get that changed as well. I'm going to try to wrap this up so we can get to the questions. There's also increased pressure on the New York State Legislature to pass GENDA, which is like those other state laws I mentioned before. It's the Gender Expression Non-Discrimination Act, which could be used as a basis for prohibiting categorical exclusions for transition-related care, among many other things. And there's also increased pressure on the New York State Department of Health and the Department of Financial Services, which in New York is the agency that oversees private insurance, fully insured private insurance plans in New York, to issue bulletins applying non-discrimination principles to private and public insurance policies, like the other states have done. So, you know, there are many ways to go about doing this. New York is kind of an illustration of one way to do it. So just to review and cap, and then we'll get to questions. The ACA provides many civil protections and helps millions of people access affordable health insurance where they never could before. But today, insurers still do not have to provide transition-related benefits under federal law. Several states have passed laws and policies that prohibit categorical exclusions of transition-related care, and yours can too. It's possible, you know, it's happening, so we can do it. And there's a lot of work being done and plenty of opportunities to get involved. And I hope that this will spark a conversation on how to get that started in your state if it hasn't already, and how to work with each other to share resources to make that happen. And that's it. So I guess we're ready for questions.
Thank you so much, Milo, for that great presentation. So if anybody has questions, go ahead and click that raise hand button, and we will get you going. There's a few questions that came in on the chat, so let me just read some of those out. Let me see. What is a good one? Here we go. One says, it is great to see some progress with states prohibiting exclusions from Medicaid. The other big hurdle seems to be finding physicians who will take Medicaid for transition costs. We don't seem to have any in Washington, and I don't know how to access a list of qualified surgeons accepting Medicaid. Milo, do you have any comments on that one?
Yeah, that's actually a very good point, and something I did not bring up. So thank you for mentioning it. Yeah, that's challenging. I think that a lot of surgeons who perform transition-related and gender-affirming services have long not participated with any insurance because it's so often been considered not medically necessary, cosmetic, experimental, you know, not even just Medicaid, but private insurance as well, because it wasn't worth the hassle for them to submit it, have it denied, appeal, because they knew they were going to lose, so they never bothered. So you'll find that a lot of surgeons don't take any insurance. So one thing that you could do with Medicaid, and I know that this is true in New York. I'm fairly sure it's true in other places, but this is something you'd want to check with your local Medicaid laws and regulations, is that often if your Medicaid is administered through a private company as a Medicaid managed care plan, which is sort of the move that a lot of states are making to administer it more effectively and more efficiently, those Medicaid managed care plans often take the shape of an HMO, or a health maintenance organization. And in that case, usually the way it works is an HMO, you have to stay in network to get the benefits, so you have to go to in-network doctors. But sometimes, if there's not a provider who is in network, who can perform the services that you need, you can get an out-of-network exception, which is where you could get a surgeon who does not take insurance or doesn't take the Medicaid plan to at least get the Medicaid reimbursement rate for that particular service. Now, the complication, of course, is Medicaid is probably much less, will reimburse much less than what they were planning to charge, right? So at that point, it's often a matter of really working closely with the provider, with the surgeon, to try to talk to them to see if there's anything that you can do to bring down the cost, to negotiate down the cost of the service. Oftentimes, if they're going to get paid something in a timely fashion, they'll provide a discount, or they'll cut off the cost of the facility fees and that sort of thing. but sometimes it's between you and the doctor. Another thing to consider is that if the surgery is taking place in a hospital or a health center that receives any federal funding whatsoever, those health centers have to provide financial assistance to people who are 300% of the federal poverty level and below. It's part of the law. So if you can get the doctor to bring down the cost of the surgical fee, and you can apply for financial assistance at the hospital or the health center where the surgery is going to take place, you might be able to get the whole thing dwindle down to something manageable. But this is definitely still a challenge that hasn't really been confronted full force yet. And you bring up a really good point, and it's something hard to take on.
Thanks for that detailed and very thoughtful answer. Other questions? I know there have been a few on the chat that I've been typing answers to. If anybody's feeling brave and wants to ask a question out loud, you can raise your hand and I can unmute you. Yes, okay, looks like Abby has her hand up. So, Abby, go ahead.
Yeah, this is Abby Jensen. Hi, Milo. How are you?
Hi, Abby.
So, you know, I'm curious about the extent that the ban on sex discrimination under 1557 could get pushed. I'm sure you're aware that Lambda Legal, I think late last year, filed a suit against a doctor or health center in southern Illinois for denying care to a trans woman who was on Medicaid, I believe, and unfortunately that the victim passed away from other causes, and so
that's right.
Been dismissed. But I guess it's somewhat related to your thought about the getting HHS to issue a bulletin banning categorical exclusions. But I guess the question is, does 1557 actually apply to individual providers or only to insurance?
So it applies to that's a good question. It applies to the insurance plans for sure. I think that I'm trying to remember the exact wording of it. I think it also applies to providers who receive federal funding.
Okay.
So hospitals and health centers and providers that receive federal funding, which, if any of them, take Medicare basically, accept Medicare, or any other sort of stipend program from the federal government. But yeah, my understanding is that it applies to anybody who's involved with federal funding, as well as the insurance plans under the ACA.
Yeah, I'll just add on to that. I'll just add on to that. That's correct. What Milo just said about any source of funding from the federal government through HHS, and that ends up counting almost every health practice, certainly every hospital. Anybody who's a federally qualified health center, so if they're serving low-income populations, there's all kinds of programs that they're involved in. So it's a pretty wide net.
Yeah.
Are you aware of anybody else trying to use 1557 in that way?
As far as lawsuits go, I'm not aware of it. I was just at a conference recently where that sort of thing was being discussed, and no one else mentioned having brought a suit about it right now, but I can tell you that the U.S. Department of Health and Human Services, HHS, is actively accepting complaints from people who feel as though they've been discriminated against, either by the providers who fall under the purview of the provision or by their insurance plans. And I know that they've received complaints from transgender individuals who are being denied coverage based on the categorical exclusions. Even though that's not technically what it's been interpreted to mean yet, they are getting complaints about it. And I always encourage people to send it in as well, because one of the biggest problems in our community is we don't know how many of us are out there, right? And so for us to say, well, such and such number of people are affected by this, we don't have those numbers. But if they actually actively get complaints and get narratives of how this is affecting people and how this is keeping them from living full, healthy lives in a purely discriminatory way, the more likely it is they'll push toward that. And I know under Secretary Sebelius, a lot of progress was made toward LGBT healthcare access with HHS, and we hope that the new secretary will be just as open and in receiving our requests and our concerns, and make the right decision. So,
great, thank you.
Mm-hmm.
Thanks for that question, Abby. Another question came in on chat that says, I currently have a Medicare Advantage insurance plan. While my plan is covering my basic HRT for the spironolactone and estradiol, they are refusing to cover an additional hormone treatment that my endocrinologist has prescribed for me. How does this decision to end transgender exclusions apply to Medicare Advantage plans?
That's a fantastic question. I don't actually know the answer to it. I would imagine that it is inclusive. But let's see, Medicare Advantage is where you are not taking the parts, you're taking the one big plan that covers everything. Isn't that right?
That's my understanding. It's an equivalent to what managed care is on the Medicare side.
Yeah. Yeah. I'm not actually sure. Anand, do you know the answer to this?
So my understanding is that, and we found out this kind of the hard way in California around a different issue with Medicare, which is that Medicare Advantage plans are not regulated at the state level, even though basically, if you're on Medicare Advantage, you're on, say, a Kaiser plan that is administering Medicare, or you're on a Blue Cross Blue Shield plan that is administering Medicare, which in most cases would be regulated at the state level. But Medicare Advantage is very kind of insistent that they are subject only to federal regulations. So the good news about that is that it means that the exclusion should be lifted at the policy level. What we're seeing so far with Medicare is that, whether it's Medicare Advantage or Medicare with Part A, Part B, and so on, is that while the policy is in place that has overturned this ban, they haven't kind of set up the internal operations level structures to implement that policy. So, at the very kind of nitty-gritty level detail of setting what the reimbursement rates are, setting exactly which diagnosis codes and which treatment codes are going to be applying to this. And the above all thing is that it's a case-by-case appeal and review situation. So if you so with your Medicare Advantage plan and they're denying your additional hormones, the best thing to do is appeal it internally with the health plan, and then also at the same time you can appeal it using the Medicare appeal processes. And if you really want to, you can also file a complaint with the Federal Health and Human Services Office of Civil Rights, HHS OCR, Office of Civil Rights. You can submit a form right online. I know HHS wants to collect these complaints because they want to be able to say to the particular agencies, hey, look, you said this policy was the rule, but you're still not really doing it. And the more cases they have, the easier it's going to be to convince Medicare to really push things into action.
Yeah, that's right. And the same is sort of true with like the states that have successfully gotten Medicaid to get rid of the categorical exclusions, or even the private insurance, that it's also relatively new, that it ends up being sort of a case-by-case appeal and push, and it hasn't really been made into a uniform process to make sure that things go as smoothly as they can. It happens sometimes, but yeah, that's right on. Thank you, Anand.
You bet. Another question came in over the chat. This one is about TRICARE. So it says, do you know if TRICARE has such exclusions? Is that subject to non-discrimination regulation as well? We recently met a family deeply concerned about losing their coverage because a dependent wanted to transition.
I'm pretty sure TRICARE is different.
Yeah, that's my understanding as well.
These are excellent questions. Yeah. These are really excellent questions. My understanding is that TRICARE and VA are different, and they follow different guidelines and different regulations, and I also know that there is a great deal of work being done by a number of advocates to try to make the entire trans military experience much well, better, but particularly the insurance as well. I'm almost sure that TRICARE is separate and is not affected by this, but I don't want to say for sure.
Cool.
But I'm definitely going to go look this stuff up after we get off of this webinar, because now I'm very curious. So.
Yeah, I'll add on to that, that the question about whether the family would lose their coverage because one of the dependents wanted to transition, I think that would be a separate issue.
Right.
Yeah, so they wouldn't be able to kick you off of the insurance. I think the worst thing that would happen is they just wouldn't cover the transition-related care for that dependent.
Thank you for clarifying that. That's true.
Sure thing. So we have time for one more question if anybody wants to ask one. It's like folks are quieting down, maybe digesting the wealth of information that we've just thrown at you. So I will close by saying thank you so much to Milo for giving your time and spending your expertise with us today. That is the citation for the Injustice at Every Turn survey, which is available free to download, and there's little spotlights on different subcategories of respondents based on race and based on gender. You can also download the full report, which I highly recommend, straight from the task force's website. If you just Google Injustice at Every Turn, it'll come right up for you.
And based on state as well.
Thank you, based on state as well. Yeah. So if you want to learn more about Trans Advocacy Network, please visit our website or check us out on Facebook. If you have questions, you can feel free to send us an email at any time through the website or directly to me, and my contact information is on the website as well. Our next webinar will be October 20th. That's also a Monday at 5 p.m., same time. And then the topic there is going to be immigrant rights for trans folks. What is happening at the policy level and what is happening on the ground for people. We will be joined by Isa Noyola of ELA para Trans Latinas, which is a group based here out of San Francisco. And Isa will give us the rundown, and she will do a very exciting job of that. I've heard her speak before, and she is wonderful. So thank you again to everyone for participating today, for asking your questions, for paying attention, and sticking through it with all of the technical details. We really appreciate that. Look forward to seeing you again at the next TAN webinar. Take care.